Hello, and welcome to the Let's Talk SADS Live, the Canadian edition of a SADS webcast. SADS, of course, being sudden arrhythmia death syndromes. And I'm your host, Dr. Shubhayan Sanatani, coming to you live from Vancouver, British Columbia. And welcome to all of you. Delighted to continue to be here and be part of this collaborative learning series that the Canadian SADS Foundation puts on, and greatly supported by our neighbors to the south, Alice Lara and Mike Ackerman at the SADS Foundation US, who, of course, started the whole webcast process, and we are shamelessly sharing the idea. So nice to be here with you, and I know many of you record these or watch them later in the day, and of course, some of you are on live, and we can take your questions and your comments into our chat. I'm just going to share my slides here. And episode 31, and we're going to be talking about arrhythmogenic RV cardiomyopathy, the evolving story of ARVC in clinical care and everyday life. So excited to have that coming up. But before we do that, a couple of announcements and thank yous. Of course, we are sponsored in part by these companies of innovation in the SAD space, so working on new treatments. And probably I've told this anecdote before. When I started my practice just over 20 years ago, it was not in my imagination that we would have so many different options for treating these rare inherited arrhythmia conditions. So Lexio Therapeutics, Solid Biosciences, Tenaya Therapeutics, and Thrive Therapeutics, all working on different approaches to these very complex arrhythmia conditions. So we're very grateful for their support. It allows us to put on our patient advocacy work and patient support, including these educational sessions and webinars. And so thank you very much. And if you want to pay it back, please go to our website, sads.ca, and check the website out, and you can donate there. Also, we have expanded our ways that you can get these webcasts, and you can listen to them on Amazon and Spotify and YouTube Music, so you can tune in at your convenience. Of course, no distracted driving, please, but you definitely can come in, join them on whatever your provider is. So our new executive director, Guido McGuigan, has been working on that, and we're excited. I think he's almost hit the 100-day mark, not quite, and so he's bringing some new ideas. Of course, Pam Husband has been leading us for decades capably. So as those of you who join in regularly know, I like to, provide a little history or something a little bit into the, the realm of other facts or did you know? And so with the weather changing in most of Canada, it's allergy season in lots of places. And of course, we have spring going in full bloom out here in Vancouver and the West Coast. So allergy season. And of course, one of the very interesting aspects of long QT syndrome is that it can be caused by medications, and many of the medications that were implicated block what's called the hERG channel, so one of the potassium channels in the heart. And this is a science paper that talks about the antihistamine stemazole, which was hismanol. And you can see there a little advert, hismanol, and it says, and it lasts, which of course is a good thing when you're marketing an allergy medication. But in fact, part of the reason it lasts is that one of the things that it's metabolized to, of course, also stuck around for many hours. And hismanol is no longer available. It's not on the market because it did cause significant QT prolongation. And so those of you who have long QT syndrome and allergies, there are lots of good options. Of course, usually long QT patients, we direct them to the Credible Meds app or website. Of course, educating your pharmacist is an important part of this. And there's there are several antihistamines there that are at the bottom of the slide. There are no risk, loratadine and cetirizine and others. So allergy season, lots of safe ways now, and that learning from the early days has really resulted in a much more strict regulation of medication, so that most medications now, that's on the radar, and we have very few QT prolonging medications coming out. And of course, talk to your physician if you have health issues other than your long QT. So, so that said, I'm excited next month to have a guest, Dr. Lauren Schneider, who is a clinical professor of psychiatry and behavioral sciences and pediatrics at Stanford, and she is a psychologist dedicated to the cardiology team down there, and she'll be coming to us to talk about some of the mental health aspects of SADS conditions and some of the impacts in the families. And I had the privilege of being on a panel with her at the Heart Rhythm meeting at the end of April, and talking to some families. So I think we're in for an exciting episode. So with all that said, I'd like to welcome a good friend and very good clinician scientist, Dr. Dominic Abrams, who is our guest today. He is the co-director of the Boston Cardiovascular Genetics Center, so at Boston Children's Hospital, and an associate professor of pediatrics at Harvard. And we're going to have him come into the studio and tell us a bit about his journey. And we're going to talk about arrhythmogenic right ventricular cardiomyopathy. So we're just bringing him in here. I see the wheels turning. There we go. That was a long trip to Boston there. All right. Welcome, Dr. Abrams. And I will likely call you Dominic.
That's fine.
Thank you so much for joining us.
My pleasure. Thank you very much for the invite. It's great to be here and looking forward to the conversation over the next hour or so.
Yeah. No, thank you. So, I mean, let's start with I'm sure many of us in the field recognize you and your name and the work, but just give us a bit of a background, because your journey is a little bit different from some of us who are spending time in the pediatric heart rhythms work.
Yeah, I had a very interesting training, as you can hear already. I'm British. I come from London in the UK, and did all of my medical school and training there, and did a sort of a variety of different things, what would now be considered to be unfocused, but at the time was great because I did a year of anesthesia and got a lot of experience there, but ultimately ended up in cardiology because that's what truly fascinated me, and initially trained in pediatric cardiology at the Brompton Hospital, which was a phenomenal place to be and a really great experience, and then became interested in electrophysiology. So there really wasn't any pediatric electrophysiology in the UK at the time, or much to speak of. So I went across London to Bart's Hospital, which is in East London by St Paul's Cathedral, and trained there initially as a fellow, and did my research there in the Fontan circulation. And then finished off because I enjoyed adult cardiology so much that I sort of stayed in adult cardiology, and I went to University College Hospital, the Heart Hospital as it then was, in central London in Marylebone, and I was doing electrophysiology there, and it was there that I sort of first had my exposure to arrhythmogenic right ventricular cardiomyopathy. And as ever in medicine, it was one of those slightly serendipitous moments. I was working with Bill McKenna, who's a fellow Canadian from Montreal, and I remember vividly Bill came up to me and said, "You go to Great Ormond Street, don't you? Great Ormond Street is, as many of you know, the big children's hospital in London, and every Thursday I would go from the Heart Hospital and we'd walk across the Great Ormond Street, and I'd do some procedures there, some EP procedures, and then clinics." And Bill said to me, "Oh, fantastic. I'm so glad you go. Could you do my ARVC outpatients that I do there once a month?" And these were all the children of the families that he'd worked up over many years, initially at St. George's Hospital and then at the Heart Hospital where he was at the time. And Bill was the chief of cardiology and obviously wanted to help as much as I could. I said, well, Bill, I'm delighted to help, but I got to be perfectly honest with you. I don't know anything at all about ARVC. It just hadn't sort of come across my radar at the time. I was very interested in the sort of more classical arrhythmic conditions like long QT syndrome. And Bill said, oh, don't worry about that. You'll be absolutely fine. And he said, basically, go to Great Ormond Street, see the families, bring the charts back to my office, and we'll go through it all. So that's what I did. Every Thursday, once a month, I would go to Great Ormond Street, see the patients. Then in those days, we had the sort of the medical, the records were actually a physical thing that you held. So I'd pick all these charts up and I'd walk back to the Heart Hospital and I'd sit in Bill's office and we would go through it. And he really it was a phenomenal experience, this kind of one-on-one tuition in the condition and the history of everything and how it came to be. Sort of discovered both from a clinical perspective and then from a genetic perspective. And as many people may know, Bill was the senior author on a paper that came out in September 2000, which discovered that plakoglobin was the cause of Naxos syndrome, which was an autosomal recessive, so a very rare form of arrhythmogenic right ventricular cardiomyopathy, very limited to the Greek island of Naxos. But because of the pattern of inheritance, it made it much easier to sequence and identify the genetic cause. So they discovered that plakoglobin was the cause there. So that's really how I first became interested in it, and sort of realized that this is fascinating. Things were really evolving at that time in our understanding of the condition. And then I moved back to Barts as what we call a consultant, which is a faculty position. And we were sort of building a inherited cardiac program there. And again, working in close collaboration with the UCL team and the Great Ormond Street team, because we were all about within 2 miles of each other. And it's there that I met someone called David Kelsall, who was a skin biologist and geneticist. And so people put me in touch with David and they said, you've got some sort of common interests in the desmosome. And David was the senior author and the senior investigator in another study that came out in the same month in September 2000, which was done in Ecuador, which was at the time referred to as Carvajal syndrome, which was another desmosomal gene, DSP, also autosomally recessive in that family, so the cardiocutaneous syndrome. And of course, David was involved because these kids had very severe skin disease. But that was the first form of DSP, or left-sided arrhythmogenic cardiomyopathy, that was described. So through a lot of luck and good fortune, I had this incredible experience of working with both Bill and David. And they really sort of both educated me in the different aspects of arrhythmogenic cardiomyopathy, but also really got me very interested in it. And here we are almost 20 years later, and it's still something that I spend a lot of my time seeing patients and doing research in. So that's my kind of journey as to how I got here.
It's an amazing story, and to have you sort of, referring to, Dr. McKenna or Professor McKenna as Bill, and sitting in his office poring over charts sounds absolutely amazing. I mean,
Yeah.
as you say, he is a Canadian that does us proud, and is this, is the author on many important documents. So wonderful. And then now, fast forward us a little bit to your current role. So because you've been really transformative in how Boston Children's looks at genetic conditions, right?
So when I came here in 2011, it was very much with the premise of sort of developing programs and helping build things and take things forward. As someone who'd worked in this transitional isn't quite right, but between the adult and the pediatric worlds before, as many people may or may not know, Boston Children's is physically connected to the Brigham and Women's Hospital, the local adult hospital, by a bridge. So we're very, very close together. So it was really to sort of try and build a more family-centered approach to this care, which we've been very fortunate to have in the UK, a lot of which was developed and driven by Bill McKenna. And so it was really sort of to try and adopt that process, and things have really gone from there. And it's been fantastic to be part of the journey, working with a great number of colleagues and friends who've been very instrumental in how this has all been built. But it's sort of feel very fortunate in, to some degree, riding the crest of a wave of cardiac genomics, because things have just expanded exponentially in the last 10 years. It's just, I always say to families in clinic, if you told me 10 years ago this is where we'd be, I just would never believe you. It was just like sort of blue sky thinking in the extreme, but here we are. So it's been a great time to be part of it, and I feel very fortunate. But yes, we've been very lucky here in Boston. We have the resources and the infrastructure here to be able to take advantage of that.
Yeah, no, we certainly are. The technology and the computerization and automation of so many things has really moved things along. We'll come back to that soon. Let's go back a bit now, because you've already educated us a lot about some complexities of ARVC, including those very, very rare forms from the Mediterranean regions. So tell us, and just remind us, basically, what is arrhythmogenic RV cardiomyopathy, or ARVD? How, it started out as a dysplasia. Now it's sometimes arrhythmogenic cardiomyopathy. So just explain to our viewers sort of how you think of these, what really is a group of conditions.
Yeah.
And we'll focus mostly on the classic, the ARVC, but I know you have a much broader approach to that.
Yeah, so I think how we think of it now is arrhythmogenic cardiomyopathy is a broad group of conditions. I personally think the best description of them is where arrhythmias are a prominent and early feature of the overall picture. There are other descriptions as well that are used, but I personally think that's a really nice one that was sort of put forward a few years ago. But if we go back historically, ARVC was actually beautifully described in Rome in the 1700s. And the description is amazing when you read it, but it was in Paris in the 1980s when Frank Marcus had gone to Paris from Arizona and was working there with the team, Guy Fontaine and others, and they recognized this condition where the right ventricle was clearly implicated. And they could see that mainly on cardiac imaging. They recognized that ECG changes reflected abnormalities in the right ventricle, and the arrhythmias were originating again from the right ventricle. So they didn't really know what it was, and so it took on this term of dysplasia. An arrhythmogenic right ventricular dysplasia seemed to be a very good term because there was a predominantly arrhythmogenic component to the condition. Over time, as the overall understanding of cardiomyopathy as a concept evolved, this became an arrhythmogenic right ventricular cardiomyopathy. And that was the term that was used for a long time and probably is still commonly used. But now we really understand things in a different way, because what was recognized, and if you go back to that description I gave in Ecuador of the Kelsall study, that the phenotype there was very much left ventricular in etiology. So what we begin to recognize was that DSP, which is another of the genes in the desmosome, was associated with much more with a left ventricular cardiomyopathy, and now we've expanded that to others such as filamin C and lamin and all sorts of other genes not in the desmosome, which also form a left ventricular form of cardiomyopathy. So when we were kind of exploring and understanding DSP, particularly where the ECG changes, the MRI changes we were seeing were very much in the left ventricle, calling this arrhythmogenic right ventricular cardiomyopathy didn't really make much sense anymore, because that's not what we were seeing. So that sort of expanded things, this term of arrhythmogenic cardiomyopathy, because we know both ventricles can be affected. And there's a very much a genotype-based approach that we take to this now. So we think of plakophilin 2, which is the gene very much associated with right ventricular forms of arrhythmogenic cardiomyopathy. Other genes such as DSP are much more with left ventricular forms. So there's been a lot of work going on recently, which I've been very fortunate to be involved with a sort of a new document that really approaches this on a genotype first basis. So we're thinking about, this is how we think about plakophilin 2, this is how we think about DSP, filamin C, RBM20, etc. So that's how we sort of think about it now. And all these conditions fall under the umbrella of arrhythmogenic cardiomyopathy, again, where arrhythmias are a prominent and early feature.
Yeah, so it's a wonderful, wonderful summary, and I'm looking forward to seeing that work that's going on. That's going to update us all and take some of this newer learning about the genetics. So let's come back to our patient now who has been diagnosed with arrhythmogenic right ventricular cardiomyopathy, or ARVC. Now, you've referred a couple of times to the desmosome, so just remind us what you're talking about when you say the desmosome.
Absolutely. So the desmosome is a complex of proteins. There's 5 of them, and it sits in the membrane of the cardiac cell, and it binds to a corresponding desmosome in the neighboring cell. So the 5 proteins are plakoglobin, desmoplakin, which are the 2 we just talked about with the Naxos and the Carvajal syndromes. And of course, from a gene discovery perspective, once 2 of the proteins in this structure have been implicated, it made a lot of sense to go and look at the others, which are plakophilin 2, desmoglin 2, and desmocolin 2. And those have now all been very much implicated in various forms of arrhythmogenic cardiomyopathy. So the desmosome acts as a mechanical link between neighboring heart cells, is one of its functions. It's quite a powerful structure and supports other things that lie across the cell junctions. But it also has a lot of other roles. So we know that desmoglin 2 is a viral receptor. Plakophilin 2 is very much involved in calcium homeostasis within the cell and how calcium functions, and also switching other genes on and off. So as always, we find the initial role of these cell structures and we think of it, we've got it mastered, but then of course we realize there's a lot more complexity to it. But that's basically what it does. So it's a mechanical construct that has a lot of other roles as well within how the cell behaves over time.
Yeah, no, fantastic. And the 2 tissues that one thinks of that really have to stick together well, obviously the heart muscle, which beats, billions of times in our lifetime, and of course your skin. So it makes sense that that there's some overlap. And as you say, these rare forms of autosomal recessive, where there's 2 abnormal genetic components, often have skin involvement with very abnormal palms and soles and hair. So now in the current era, most patients will have genetic testing to confirm their arrhythmogenic cardiomyopathy type. And in your clinic, are you routinely offering genetic testing to all comers with cardiomyopathy, or are there certain select ones that don't get it? Or
no, I think we offer it to everyone. We have a great counseling team who help and see the patients. We have a psychologist who helps support in the decision making. But we do make it so, we think it's important. It really helps us as a team understand how we need to investigate the patients and how we would think about the longer term natural history. We would investigate plakophilin 2 very differently from DSP in terms of the timing of different investigations, particularly in people who are known to be genetically at risk. So they have the change that's been identified in the family, but they have yet to show any features of cardiomyopathy. So it is something that we offer broadly, but we always say, a conversation we had this morning, we're here to help you make the decision that's best for you as a family. And some people are by nature, they want that information, they want to test immediately. Other people wait much longer. Some people wait until their children are 18 and they can make their own decision. So we've seen lots of different patterns of how people approach it. But I think it's something that we always offer, or we'd always offer it, and really sort of help people think about what it means to them. And of course, with all these things, it's a test that's very easy to do now, but understanding the implications of what this could mean downstream is very important, that those expectations are set early in terms of, well, if we find this, this is what this could mean. If we don't find this, this could mean this. So the counseling beforehand, and we have a great team who help with that, is really key.
Yeah, and I'll definitely emphasize that, especially when you are going to test for something that may have lifelong implications, particularly in someone who at the time may not have any evidence of disease. So let's focus maybe on plakophilin as sort of just the most common of the genetic variants in ARVC. So I think even within our field, there's some practice variation. I think all of us should definitely be doing the genetic counseling piece. I think some people have challenges accessing that resource. Yep. That seems to be the nature of healthcare currently. Is there an age that you start the conversation? I know documents used to say, we don't need to talk about ARVC until kids are 12 years old. The original description, the 22 patients or so, they excluded children under 12. And so at what point, if you have a parent who has ARVC and has a positive plakophilin genetic variant, what do you sort of counsel them in terms of when should they think about genetic testing, recognizing it's individual for every family?
Sure. So I think with plakophilin 2 now, there's been a lot of research around the genetics in terms of understanding the different variants that we see in the gene. And all of these are founders. So they all go back several hundred years. So we see the same ones recurring time and time again. From our perspective, that means that we feel very comfortable with many of these changes saying, yes, we believe this is the cause of your arrhythmogenic cardiomyopathy. And that's obviously important if you're going to test for it and then act on that result. So from a genetic testing perspective, many people bring children in at all ages. We see kids from babes in arms all the way through to older teens. But I think given our understanding of the changes in PKP2, we feel very comfortable if people want to test at a young age, then that is entirely appropriate and we would support that. Obviously, if that's negative, then they can forget about it and the kids can go and do what they want to do and not have to worry about recurrent visits and all the other implications of a positive test. But if it is positive, then we sort of make a plan for the family as to when we start to think more seriously about clinical investigations. And we really start around the age of 8 to 10, because that's when we now know that, yes, we used to think it was sort of 12 and a bit older, but we're starting to see things younger. And obviously we want to err on the side of caution. So we usually start sort of clinical screening in earnest around the 8 to 10 mark, which is often when people are starting to do more, kids are starting to become more active. And that's usually a good time to start investigating that, because certainly we, and I know many others, have not seen anyone younger than that who has just what classical heterozygous forms of PKP2, so one copy of the gene is altered.
And you and your colleague Robin Hyland, who I believe is a genetic counselor, you produced an important paper on if you had a plakophilin variant, the likelihood of developing ARVC, it was quite restricted. So there were quite, my takeaway was that there are a lot of people walking around who have plakophilin variants that don't have ARVC or are not at risk.
Yeah, so I think when you're thinking about any genetic condition, it's really important to look at the whole population at risk per se, and that's everyone who has a change in plakophilin 2 that could potentially be associated with arrhythmogenic cardiomyopathy. And we know those are all a specific type of change called truncating. So they can basically cause that copy of the protein never to be produced. Obviously, what we historically have seen in cardiology clinics are families who have a condition. Someone has clinical symptoms, so they come and see it. And so that was the patient group that historically we focused on, because that was exactly who we saw. Sort of going back to the comments we made earlier about the technology and the advances of our understanding, we've now got these huge databases of individuals who very kindly given their DNA for research, which has allowed us to understand what is genetic variation in the population, what does that look like? And a lot of this has been done at the Broad Institute here in Boston or in Cambridge. And what we were seeing was this pattern of the genetic changes in plakophilin 2 that we were seeing in patients with arrhythmogenic cardiomyopathy who were coming to the clinic and have been reported many times in other families at other centers, but we were seeing these in the population at quite a frequency as well. So the study that we did was really to try and understand that whole spectrum from the really sort of severely affected individuals that we were seeing in clinic with important forms of cardiomyopathy all the way through to the other end of the spectrum, which was people who are completely asymptomatic and have no idea they have this. So I think it's important to put that around the context of when we looked at that population in the UK Biobank, we found about 1 in 1,000 people had a plakophilin 2 variant that should or has been associated with arrhythmogenic cardiomyopathy. But only a very small proportion of those, 3 out of 200, actually had features from the records available to us that suggested they had any form of cardiomyopathy or had any symptoms related to that. And that is clearly one end of an important spectrum. And at the other end of the spectrum is people who have multiple affected family members, and there's clearly a condition segregated within the family that's associated with the same genetic change. Why those two things differ is, of course, something we're really trying to understand. What are the factors that promote the development of cardiomyopathy in one family and not in another? But what's also important that we found was that all these genetic changes are the same. So the ones that are most common in families with arrhythmogenic cardiomyopathy were also the most common in the UK Biobank in people who didn't know they had any condition. And we know that all these things track back several hundred years. They go back many, many generations. So the way we sort of think about it, rather simplistically, if you like, is you think of a mountain range. On the snowy peaks, we have those who are affected by ARVC, so the probans, which is the first member of the family to present, and then some family members who also have various features that are associated with ARVC. As you get lower down the mountain, you get further away from the affected individuals, and so in the valleys, there's all these people who also have PKP2 variants. And then, of course, you're going back up the mountain the other side, back up to the snowy peaks. So we sort of think about it as the higher up the mountain you are, the more likely you are to be affected with ARVC. But we know there's all these people out there in the population who are in the valleys who we've only just really learned about over the last 5 or 6 years. And now we're beginning to shift our understanding, but also our emphasis in people who are genetically predisposed, who don't have the condition, but those who are genetically predisposed and who don't. So it's just been a really interesting frame shift in looking at the overall population, because we now are beginning to understand actually what that is and what that means.
I like the analogy of the mountain, of course, and you know, and it sort of gives us a visual also that the number of significantly affected people is usually much smaller than the number of people carrying the risk. Before I want to jump into exercise, but I want to circle back to, you had mentioned one particular point that I wanted to come back to. So one of Frankus, Mark Frankus, and Frank Marcus, struggling with that this morning, and Guy Fontaine, of course. They, especially Professor Fontaine, really talked about myocarditis. And so, until we had the pandemic, I don't think anyone talked about myocarditis, and now it's sort of in everyday parlance. Myocarditis is, it's an inflammatory response in the heart, often caused by, a viral trigger, and so there's this hypothesis that to develop ARVC, you might have to actually, have an inflammatory process, possibly from a viral myocarditis. Have you or your group done any work on that, or is it sort of it's just sort of out there and we haven't really proven that?
So it's an area of great interest that's really ongoing, because it's increasingly recognized, as you say, that inflammation is a key component of many cardiomyopathies, and certainly the arrhythmogenic ones specifically. If you go back 20, 30 years, one of the hypotheses before we understood the genetics was that this was a condition that was started by some viral infection. There's many viruses that we know can cause infective myocarditis. And then the patient either for some reason never recovered, or there was a persistent process of remodeling of the heart and changing of the heart that led to this form of cardiomyopathy. But the evidence was never really that robust. The people could never demonstrate that those with arrhythmogenic cardiomyopathy had a higher prevalence of viral infections or viruses that could be isolated from the myocardium. So it was always more of a hypothesis than a theory, than sort of evidence, which then, of course, significantly fell away when the genetics was discovered and we realized this was primarily a genetic disorder. But it was also recognized in certain genetic subgroups, and DSP is the classic one, that inflammation is a really key part, not just of the early phase of the condition as we initially suspected, but also that can persist throughout the natural history of the cardiomyopathy. We've seen it, as have many others, primarily associated with the gene DSP, and so the left-sided forms of the condition, and patients will present with chest pain, changes sometimes on their ECG, and a release of troponin in the blood marks, so markers of cardiac inflammation. And it often settles down and people look for viruses, and then they're told it's all fine, it's got better, and then till it happens again. And we often see this as recurrent. And when you take family histories, many of the parents will say, yeah, I had myocarditis 3 times, but they could never find the virus and no one knew why. So it's that recurrent finding that is really typical of arrhythmogenic cardiomyopathy. Quite what it is and how it starts is still an area of much investigation, but it seems to be something localized within the heart cells. So it's innate to the condition. And about 20% of patients with DSP-mediated cardiomyopathy will have some history of this in the past. And so we've now got a wonderful cohort led by the team at Johns Hopkins called the Desperados cohort, specifically focusing on those with changes in DSP, which is now numbers over 1,000 individuals. So we can really start to understand the number of people who have infections and try and have inflammation and myocarditis, and try and understand potentially why that is, why did that affect them, or what's causing this. Of course, if we can modify inflammation, can we somehow modify the cardiomyopathy as well? Again, that's a great question that we're working on. So yeah, it's an area of great interest, but really is now recognized as something that's inherent to the condition overall.
And I think, we'll just restate for our viewers and our patients out there, I don't think anyone has enough information that we would say that you somehow have to live in a bubble and try never to get the common cold, or your ARVC is going to flare up. I think it's more complex than that, but certainly in some patients at risk, these flare-ups, these inflammatory flare-ups, are part of the condition.
Yeah. So
let's come back to the one of my favorite topics is activity. People have gone, people have taken patients with ARVC and looked backwards and said, well, you were more active and in your sports. And I think it was you actually that gave me the very humorous interpretation of how a somewhat macho middle-aged man might respond to the young research assistant to impress them. So tell us a bit about your approach. So the family has this child who is 6 years old and has a PKP2 variant. Are you trying to modify their exercise? What's your practical approach?
So I think just to sort of put it into historical context, it was known for some time that there was just a high proportion of people that we were seeing in the early days, and I'm talking 15 plus years ago, with arrhythmogenic cardiomyopathy who seemed to have a history of classically long distance running. They'd done marathons, triathlons, all sorts of things. And that was a pattern that was occurring. And then it was really the team at Johns Hopkins, led by Cindy James and others, who took this forward and really began to develop this association between arrhythmogenic right ventricular cardiomyopathy and plakophilin-2 and exercise. Because plakophilin-2 is the gene we very much associate with ARVC, and it's the right form of the condition that seems to be most associated with exercise. There's a lot of physiological basis behind that, and that when you do exercise, the right ventricle takes a relative higher burden of stress and strain than the other ventricle, the left ventricle, does. So it sort of makes sense that if you repeatedly exercise, you may be putting stress on the heart muscle, and if you've got an inherent weakness in that muscle, you may bring it out earlier. And so that's what they showed. But again, Hopkins is a wonderful center. They have an incredible program, but they tend to potentially attract a unique end of the spectrum and a unique population. If you're a very committed triathlon runner in Oregon, let's just say, for example, and you think, well, I've heard about this great center in Baltimore, I'm going to go there, they may attract a specific population. So again, it's really important to understand everyone within that spectrum of who's at risk of developing ARVC and what's the exercise they do. So now, of course, we have all these other patients that we know of through databases, and one of the things that would be really interesting is, well, how much exercise did you do? But we'd all started to see families where, you know, a 15-year-old comes in, we make a diagnosis of ARVC, then you think, well, this is almost certainly coming from one of the parents, and one of them runs 10 miles a day and is really athletic, the other one much less so. And of course, when you think it must be the one who's much less so, but no, it's the one who's really athletic. So there were these patterns that weren't entirely consistent with the exercise feature. But until we really understand that much larger proportion of people who are genetically at risk, who we don't yet really have good access to, and assess their exercise activities, it's much more difficult to understand the broader picture. But I think what we know now is that there's clearly is an association between the two, but that it doesn't seem to affect everyone. And it's not, there may be a far more nuanced explanation, which is almost certainly true, because we're finding all these other patients now through other mechanisms who don't have cardiomyopathy, who seem to exercise without any problem. So what is it about that specific end of the group that causes them to have issues with exercise? So the way we approach it in clinic is it's a lot of conversations ahead of time that often predates the genetic testing, and just explaining how we think about things. Our approach is very much like many now, is a joint decision-making strategy with the family, letting them, again, come to the decision that feels right for them and supporting them. But if people are genetically predisposed and don't have any features of the condition, then we let them continue doing the things they want to do. And some people, as we know from a lot of the work that many have done before, will just decide that it's not for them. They just say, you know what, this risk is too much, I'm going to do other things. And people find very other successful and enjoyable activities to pursue that are less strenuous. But for those who wish to continue, we monitor them very carefully. I think in young patients, the Holter monitor is probably the best test we've got, just a good old-fashioned Holter. And so if everything continues and we don't see any features, then we do let them continue with all sort of safeguards in place, etc. And then you sort of monitor things going forward and continue like that if there's no emergence. But if things start to appear, then obviously we have a different conversation and reframe things. But I think as in so many things in life, it's a balance between exercising potentially too much that you're worsening your cardiomyopathy, but ensuring that you maintain the benefits of exercise and all the positive things that brings to all of us in so many ways. We all learned through COVID how important it was to our mental health, our long-term risk of cancer, long-term risk of joint disease, all these kind of things. There's a lot of benefits of exercise. So it's really, as the team at Hopkins was saying when I was down there recently, exercise moderation, finding a balance that works for any one individual. But that's very much how we approach it. But it's the first meeting with the family is the beginning of a very long conversation to really find a place that they feel comfortable with and understanding exactly what we're talking about and what the potential risks are.
Yeah, I think that's it is that nuanced discussion, and the child needs to be at the center of it and included in. And it's exciting to think that the data is going to develop over the next probably 5-10 years as we start looking forward a bit instead of the current. Most of the data currently is looking backwards at people who already have the condition. So it'll be interesting to learn. So just as we're kind of approaching the time here, I do want to bring us back to our Canadian features, and I think you had some interaction with the Newfoundland group, and they of course, Newfoundland has this founder population of arrhythmogenic cardiomyopathy from a TMEM43 variant. We've had Kathy Hodgkinson on our show and talked about it. What was your Newfoundland experience? Did you visit there, or did you had some collaboration or work?
Yeah, it's wonderful. So Kathy and I met in 10 years ago now. I was giving a talk at a conference and she came up and spoke to me, and I was quite new to the US and still learning, and someone came up and spoke to me in this very northwest of England accent, and I was thinking, God, who's this? And she introduced herself, and we just got on very well, and so we sort of stayed in touch over the years. And then I visited. They invited me to visit in 2023, so 18 months ago. And I went up there, absolutely fantastic. You know, what they've achieved and what they've done there is incredible with a population, how it really is understanding genetics in a really pure form of this very large population, and really understanding the spectrum of different forms of cardiomyopathy that TMEM43 is associated with. And of course, they have this unique experience. So for me, it was incredibly educational to learn from them about the process, to learn from them about their understanding of cardiology, and just to sit in with them in their meetings and understand how they manage their patients. We see very few patients with TMEM43, in fact, one, I think. So it was just a really, really unique experience, and a great team up there. It was a lot of fun. And Kathy was a wonderful host. We had a great time. She took me on tours to Cape Spear and around St. John's, and it was a really, really good time. So yes, it's very exciting. And we really hope to continue that collaboration with them. And you know, they're working in an environment that is sort of different in many ways to certainly what we have here in central Boston, where we think, can you just pop up for the MRI on Tuesday afternoon? Whereas there, you know, people are living 12 hours away in a fishing village on the north coast of the island. It's a very different way of thinking about outcomes and genetics and cardiology. So yeah, it's really exciting, and it's a great place, and I certainly congratulate them enormously in what they've done there. It's fantastic.
Well, excellent. And yes, so we enjoyed having Kathy on the show. Dominic, thank you so much. It's always a pleasure to talk to you. You have such a vast experience and nice approach to these very nuanced conversations. Your team is really doing some great research in this space that all of us are benefiting from, and it really has been a pleasure. So I look forward to reading more of your work and to catching up again.
Thank you. It's been great. I've really enjoyed it, and honored to be part of the webcast. Thank you.
All right. Thank you. So, yeah, lots of complexity in arrhythmogenic cardiomyopathy, and you know, there are other types. We didn't even get to the, you know, talking about these forms that have mostly left ventricular involvement. So, as always, it's really a privilege for me to be part of these conversations. I learned so much, and I hope you do as well. Feel free to reach out to the SADS team and give them your feedback and topics maybe. Check out our website, where we have a lot of excellent resources already. So until next time, I'm your host, Shubhayan Sanatani, and it's been wonderful learning with you today.